the field of rickettsiology since I was an infectious disease fellow in Dr. Walker's lab, mainly at the bench and doing some field work. As an infectious disease physician, starting to see cases of murine typhus in Galveston allowed me to sort of bridge what I was learning in Dr. Walker's lab with what we were with my clinical skills, my clinical training. So that's been very satisfying. So I'll be talking about the epidemiology and clinical features of Flea-borne Rickettsioses, with an emphasis on the Americas. So first, after a brief introduction, I'll talk about Rickettsia typhi, the epidemiology and clinical features, move on to Rickettsia felis, and finally spend maybe a couple minutes speaking about some Rickettsia felis-like organisms. So I think in the next couple of days or a few days, we'll hear a lot about spotted fever group Rickettsia, a lot about the transmission of Rickettsia from ticks. But Rickettsia, like Rickettsia prowazekii, can be transmitted by lice. Certainly oriented Susagamushi transmitted by mites, as well as Rickettsia offering. But today I'll just focus on the flea. So Rickettsia are divided into three different sort of biogroups, or main biogroups. The spotted fever group, which consists of over 20 species of Rickettsia, a transitional group, and then a typhus group. And what we'll be talking about is an organism in the typhus group, Rickettsia typhi, and then an organism in the transitional group, Rickettsia felis. So Rickettsia typhi causes murine typhus, and it is also called endemic typhus for reasons I'll explain later. And Rickettsia felis, to my knowledge, really doesn't have a good official name, but the one that I like that appears in the literature is flea-borne spotted fever. So murine typhus. So murine typhus is endemic to much of the world. It is seems to be more of a disease distributed along coastal seaboard regions. And the reason for this is the classic reservoir. So the classic reservoir are Rattus species. Rattus species originated from Central Asia, disseminated throughout the world. And wherever you find humans, you will find rats. And through trade, whether it be via land or sea, rats have proliferated the earth as us humans have. This is a picture of Galveston Harbor in the 1920s. There was actually a plague outbreak in Galveston in the early 1920s. And long ago, people recognized the association with rats and disease. And during this plague outbreak, they actually implemented these devices along the lines of these ships to help keep the rats from going from the ship to the harbor. And so we know that ships harbor rats. Ships go all over the world, and these rats can carry all sorts of diseases like murine typhus with them. So murine typhus is the classic transmission cycle, or some people refer to it as an urban cycle, involves rats. The reason some people refer to it as an urban cycle is because many of these rats are in large cities, port cities, places where the population density of people is very dense. The primary vector is Xenopsula pyophis, which is the oriental rat flea. So rats, when they do not get ill with Rickettsia typhi. They don't die, don't exhibit any sort of ill effect, and they remain rickettemic for at least 3 weeks. So when a rat is infected, it will have rickettsia in the bloodstream for a long time. And feeding fleas can acquire the rickettsia from these rickettemic rats. So the fleas remain infected for life. The lifespan of the flea is not changed by being infected. And the infection involves a midgut of the flea. And the flea sheds the rickettsia within its feces, and the rickettsia can remain stable within the feces for weeks. So it's the feces that is the path with rickettsia, and probably the most likely way that this is transmitted is when the rickettsia-laden flea feces are scratched into a flea bite site. Another inoculation, or another way that this can be inoculated is through mucous membranes. So the flea feces onto the hand, perhaps rubbed onto the conjunctiva or other mucous membranes. It used to be called, or at one time was called, shock typhus, because it was associated with typhus that occurred in people that either worked in small stores or went to groceries where there were perhaps lots of rats because of produce and other goods. And I imagine someone sweeping up after a long day of work, sweeping up the flea feces into the air. Experimentally, it has been shown that the flea can infect at least rats by flea bites, but it does seem to be a minor mechanism of transmission. So in the United States, murine typhus was actually a relatively common disease. It was very common on the southeastern part of the United States, or the very southern part of the United States. And in Latin America, there's actually, in the last few decades, starting to see more interest in this disease. But there were decades where there was not a lot reported in regards to Rickettsia typhi infection. I'll go over this map a little bit later, but wanted to just demonstrate some sites in red where there have been some seroprevalence studies, and some sites in that orangish yellow where there have been some, or actually documented cases right now, and active cases. So in the United States, when murine typhus was relatively common, there was a peak in the 1940s. Many cases were being diagnosed. And then something remarkable happens when you look at this graph. There's a sharp decline in cases after around 1946. And the reason for this, at that time, or during World War II, there was a development of this potent insecticide called DDT, and they were using it for everything. We now know that DDT can be detrimental to the environment and to animals, so it's no longer used. But it was used for everything. They sold it to people to use on their homes, people would put it on their clothes. It's just amazing to think about what people were doing with this. And there were campaigns to control murine typhus in the United States using DDT specifically in areas where rats lived. And they would put the DDT on the rat runs. And it's been documented in several studies, but I'll show one that's more applicable to me because Galveston is where I now live. At one time, in this study, 58% of rats were infested with fleas. And 63% of the rats had antibodies to Rickettsia typhi, demonstrating that they had been exposed to Rickettsia typhi. Well, after the application of DDT, the number of rats that were infested with fleas, specifically Xenopsilochiopus, dramatically decreased. And the number of rats that were positive had typhus group antibody positive dramatically decreased. Now, we don't see that fleas were completely went away. We don't see that there's probably some Rickettsia typhi still around, as some rats were seropositive. But for some reason, bringing down the level to a certain extent just broke the cycle. And for decades, we thought there was no murine typhus in Galveston. And that was true for much of the United States. This is another study that documented this phenomenon. Up here we see these are 3 counties in the state of Georgia in the southeast United States. Each shaded box is a case of murine typhus. And this is a control group. No DDT applied to this county. And in these 2 counties, DDT was applied during these time periods, during 1946 and 1947. You see clearly during the campaign of applying DDT, there was a well-documented decrease in cases of murine typhus. So the use of DDT is actually DDT murine typhus is just an amazing story of how vector control can actually control the disease. Now this is not well documented in Latin America, this DDT phenomenon of murine typhus. But DDT was used extensively to control malaria, so it was to kill mosquitoes. And other insecticides were used in an effort to control Chagas disease. Although these may have been applied, these insecticides may have been applied differently, it is very possible that they affected the epidemiology of murine typhus in Latin America. So I described murine typhus just sort of going away, dropping off the face of the United States, forgotten by clinicians. But there's always been, in the decades after DDT, there's always been cases in two places in the United States, and that's the very southern counties of Texas along the Rio Grande border and in Southern California. So this is a map from 1969, but this would have been no different, or looked not much different in the 1980s. But in California, where murine typhus seemed to remain endemic, someone noticed something different. Rather than being in the city of Los Angeles, where there was a dense population, where you might expect a dense population of rats, they started seeing cases of murine typhus out in the hills, in the surrounding part of the cities, the suburbs. And when investigators looked at this, they didn't find rats that were seropositive for Rickettsia typhi. They didn't find fleas on these rats that were infected with Rickettsia typhi. But what they found was possums that were seropositive. And since then, possums have been implicated in the transmission of murine typhus in Southern California and in South Texas. Now, certainly the really well done methodical experiments involving fleas and rats have not been performed on involving possums, but it appears to be that possums are involved. And in Texas, these southern counties seem to be, the possums were implicated in the disease. But over the course of years, there seems to be an increase in cases of murine typhus in Texas. A little bit of this in the mid-2000s may have been due to some active surveillance in the very southern counties of Texas. But that program wasn't that aggressive, and I believe it only took place for a few years. But it really seems like there's an uptick in cases. In 2008, there was 33 cases described in the state of Texas capital, Austin, where murine typhus was off the map for decades. And in 2012, we diagnosed a case of murine typhus in Galveston. So Dr. Walker and I used to have hallway conversations, and we wondered why, or we just thought, why does murine typhus exist in the city of Corpus Christi, 300 miles southwest of Galveston on the coast, a port city like Galveston, a city right on the water like Galveston, a city with a similar climate as Galveston? Why don't we have murine typhus anymore? And it had been well documented that murine typhus had disappeared from our area after the use of DDT. Well, we saw one case in 2012 in April. We saw another case, I was involved in another case in October of 2012. And that's when Dr. Walker and I decided, hey, you see one case that's interesting, you see two cases, maybe we're onto something, we need to study this. And since then, we've found dozens of cases in Galveston and in Galveston County. And all these red stars aren't even up to date. I got tired of putting red stars on this map. And it used to be where I knew about every case of murine typhus because people knew I was studying it, people knew I could help them make the diagnosis or give them advice. Now, our medical students and residents are so aware of this that they're making the diagnosis without even, I don't even know about these patients sometimes. So what we found in Galveston, we decided after finding many cases and describing a sort of reemergence in our area, we hooked up with the local the animal control officers and actually collected possums and found that 2/3 of the possums that we collected spread across all over our island were seropositive for Rickettsioses. And 7% of the fleas that we collected on these possums were positive for Rickettsioses by molecular analysis. So it really appears that the possum is involved in the cycle now in Galveston. And I don't have it up as a slide, but people have also often asked us about domestic animals. So we actually looked at the feral cat population and found very little Rickettsioses within the fleas collected on these cats. I believe that the number is like 0.3% minimum infection rate, so very low. And this is a study conducted by the Texas State Health Department that was recently published that describes the epidemiology of murine typhus in Texas over the last between 2003 and 2013, so a 10-year period. And what we find is there are still many cases in the very southern part of Texas. But if you look at these red circles, these are where counties where cases have been reported since 2007. So in the latter half of the reporting period, there appears to be more murine typhus in northern counties. Now, whether that's related to spillover of the vector into new reservoirs, into new possum populations north, or is that related to awareness? I think physicians, we would love to think that we are educating the community and the community of doctors to make this diagnosis, but most people, at least in Texas, don't even know what murine typhus is. So we don't really know what is going on here, but it's interesting. So now I'll switch gears to Latin America. And we know that there is a high prevalence, seroprevalence in Mexico City of Rickettsioses. There's also a high prevalence in Colombia, a relatively high prevalence in Iquitos, and a very low seroprevalence in a couple of studies performed in Argentina and in Brazil. Right now, there are active cases being described of murine typhus in the Yucatan, here in Colombia, and I'm excited to learn more about this later in this Congress. And it was a very interesting case report in Brazil. And I liked the case report because they went into a lot of the history regarding murine typhus in Latin America, but they also described a patient with severe murine typhus who worked in a warehouse, and he admitted to the physicians that I believe the story was when his boss left the warehouse, he would go off and take a nap on the grains or sacks of grain where there were many rats. So I guess maybe laziness on the job is a risk factor for murine typhus. So I talked about possums, I talked about rats. I'd like to point out that the fleas that live on possums, ENICIP felis, also feeds and lives on cats and dogs, domestic animals. And there have been studies that have found Rickettsia typhi on fleas collected from these animals. Don't know if these animals are a good reservoir. Are they bacteremic long enough for other fleas to acquire and then transmit to other organisms or humans? And to my knowledge right now, that's unknown. So in regards to clinical features, This is a slide that Dr. Walker previously showed. Like the spotted fever group, Rickettsiae, typhus group has tropism for endothelial cells. And the inflammation of the endothelial cells causes the basic pathophysiologic mechanism of injury in the human. Increased vascular permeability, edema, intravascular volume depletion, which can lead to hypotension and hypoperfusion, decreased organ perfusion, and then end organ damage like acute kidney injury, the pulmonary edema, meningoencephalitis, and finally, in severe cases, death. So, there is a triad that people have described in the past with urinary typhus involving fever, headache, and rash. But this quote, classic triad, is rarely seen when described in large case series. Only 35%. Fever and rash, only 53%. This is a disease that causes sudden onset fever. All patients have fever. Following that, people often have headache. Patients describe the headache usually as the worst headache they've ever had in their life. They have muscle aches, chills, and malaise. And about a quarter of patients will develop respiratory symptoms, including cough or abnormal chest x-rays. And some people with severe disease can get pulmonary edema and wind up on a ventilator. Laboratory findings include elevated hepatic transaminases in 79%, so very similar to spotted fever group Rickettsioses, but also very similar to other acute undifferentiated febrile illnesses. See thrombocytopenia in many cases, sometimes leukopenia. I'm going to go back to rash. Rash is seen in only 48%. So this is a kind of a meta-analysis of large case series where they pulled the data together and they came up with a number of 48%. Other series say a little bit higher, a little bit lower, but I really like the 48% because to me it's very close to 50, and 50% is easy to remember. So half of patients will not have the symptom or the sign that would clue a physician into a rickettsiosis. So this is a macular rash on the trunk of a patient with murine typhus. It's a little faded out in this picture, but he had a very clear rash. This is a macular rash in a patient who actually did not present to the hospital with a rash, and he was being examined daily by physicians. Was in the hospital for about 10 days as physicians were trying to figure out his diagnosis. And somewhere during this hospitalization, someone noticed this fine macular rash, which ended up leading to the diagnosis of murine typhus. This is I believe, a Caucasian male who didn't get out in the sun much. He was very light, and he had a very faint rash on his feet. Noticeable, really only noticeable are by the patient who informed the doctors. This is an African American man with very hard to see, but a few macules. And this is a rash that doesn't hide. This is a petechial rash in a patient that was admitted to the ICU and was very close to being put on a ventilator for supportive care because of respiratory distress. So in regards to this rash, we know that one study done in New Orleans, Louisiana, where the population of the hospital was either African American or Caucasian and light skinned. The lighter skinned individuals had rash 80% of the time, The African Americans had rash 20% of the time. In darker pigmented individuals, the rash is harder to see. What we know throughout the world, it's probably more along 50%, 48%. So I alluded earlier that murine typhus can be very severe. It is generally thought of as a mild illness. The case fatality is relatively low. In a recent study, the recent manuscript that came out, there were only 11 deaths between the years 1985 and 2015 in Texas. And this encompassed 3,048 cases of murine typhus. So a case fatality of 0.4%. Now, if someone is unlucky enough or sick enough to get admitted in a hospital, that number is larger, and it's up to 2%. So in regards to the differential diagnosis, what causes, or what do we need to think about in regards to the differential diagnosis? There are many things. I mean, this is an acute undifferentiated febrile syndrome. So certainly anything transmitted by a tick, like rickettsia, anaplasmosis, or lichiosis, leptospirosis, mosquito, all sorts of mosquito-borne viruses, and finally malaria, as well as other community-acquired viruses like C and V. I've even seen people with secondary syphilis who someone thought had murine typhus. So really, the key to diagnosis is clinical recognition. Clinicians have to know about this disease to be able to make a diagnosis and to effectively treat it. Unfortunately, there are no rapid point-of-care tests. And unfortunately, I mean, I think everyone in the field is aware of that limitation in regards to what we have with diagnostics. So as of now, serology is the mainstay of diagnosis. But unfortunately, a serologic diagnosis is a retrospective diagnosis. It is very important, as with any rickettsiosis, not to wait for confirmatory testing or serology before starting treatment. If a physician thinks about the rickettsiosis, they should be treated. The typhus group immunofluorescence assay is the gold standard, but ELISAs are available. In regards to getting a definitive serologic diagnosis, it really usually requires getting serum during the convalescent phase. So seroconversion from acute and convalescent phase serum, or a fourfold increase in titers from sera obtained during acute convalescent disease. But that's a very hard thing to do. That is very easy to say. But guess what? When you treat someone with doxycycline and they feel better 2 days later, they don't want to come back to the doctor. Again, diagnosis is retrospective because antibodies are rarely detected in the first week of illness. As seen in this graph, in a series of patients with murine typhus in Corpus Christi, Texas. Here at 7 days of illness, only about 15% of people have a detectable antibody titer. So I cannot tell you how many times I am speaking to a resident or a student or even a faculty member at my institution, and they come up to me and say, this patient cannot have murine typhus. Their antibodies came back and the IFA is negative. And we stopped doxycycline now. And no. This is a message that seems to be very hard to teach. There are ways to make an acute or a diagnosis during the acute phase, and this includes immunohistochemistry. So the immunohistochemical detection of the organism within tissues. But in this case, you have to get the biopsy from an area where there's rickettsia, which usually is a rash. Only rash in 50% of patients. So this is not available in much of the world. Available in only a few places, at least in the United States, and only 50% of people would ever have anything to biopsy. PCR, amplification of rickettsial DNA from the blood and skin, works, but unfortunately, PCR has a very low sensitivity in this disease from peripheral blood samples. So the sample that most clinicians would have easy access to. And a number recently in a nice review article was that accumulated data from many papers reporting PCR 18% sensitivity. So this is hard to diagnose. And I was working with a fellow, infectious disease fellow, who was helping me collect cases. And one thing that he noticed, his observation was that these people stay in the hospital a long time. They seem to get admitted to the hospital when they don't need to be put into the hospital. And it takes people a long time to diagnose them. And many times these people have gone from doctor to doctor before getting a diagnosis. So what we decided to do is we compared patients with probable or confirmed murine typhus to those with another undifferentiated febrile illness, influenza. Now, influenza is different. It's very seasonal. It occurs in the winter months. It does have more respiratory symptoms. But many people describe murine typhus as being flu-like. So we compared age-matched, sex-matched, severity-matched patients with influenza in a 3-to-1 ratio, 3 influenza to 1 murine typhus, and just looked at parameters regarding their hospitalizations. And what we found was people with murine typhus have many more healthcare encounters with a physician before a diagnosis, a presumed diagnosis is ever made. The time to a presumptive diagnosis is much longer. So, diagnosis of influenza occurs usually at the bedside with a point-of-care test, whereas obviously it would take a long time to get serology. So what we said, we compared those with a positive point-of-care test for influenza with those who had a presumptive diagnosis of murine typhus, not confirmed, but where the physician said, I think they have murine typhus, I'm starting doxycycline. And the difference was still huge between 2 versus 9 days. And finally, hospitalization costs are much higher than those with murine typhus. $16,000 for patients with murine typhus versus $800 in those with influenza. And this is just healthcare costs, not necessarily hospitalization costs, but healthcare costs. And the groups, when being put into the study, were really no different. We could say that, well, maybe one group was more ill than another, but at least by a very commonly used severity score, the groups were very similar. And both had by this score an estimated 4% case fatality, estimated. Now, no one died in this study, but this is just based on the severity score. So that really tells us we need a rapid point-of-care test. Hard to diagnose, and because of that, people don't get treated on time, and a lot of money is spent on these hospitalizations and healthcare. So in regards to treatment, it's key to know, like any rickettsiosis, that we should not withhold treatment while waiting diagnosis. And tetracyclines are the antibiotic of choice, especially doxycycline, which has a better gastrointestinal tolerability profile and is not altered in regards to absorption with food and is readily available. Although not available in the United States, chloramphenicol is available in much of the world and is an alternative. I would never say this about Rocky Mountain spotted fever or disease caused by rickettsii, but in the case of a less severe illness, fluoroquinolones like ciprofloxacin have been used with murine typhus with success. And there has been some case reports of azithromycin working in patients with murine typhus, say pregnant women when people didn't want to use either chloramphenicol or doxycycline. And this graph is from a case series in Greece where they retrospectively, it was a retrospective study where they looked at patients treated with different antibiotics and really see that time to defervescence is much faster with doxycycline than it is with other agents. And we do know that in a very severe disease, Rocky Mountain spotted fever, doxycycline is more effective than chloramphenicol. So with that, I'll move on to flea-borne spotted fever. And so this is a flea-borne spotted fever, or Rickettsioses, was found within, Rickettsioses was an organism found within Tenacephalides felis fleas in a laboratory-derived flea colony. And it doesn't seem to affect the fleas. It's transalveolar passage for many generations. I think one paper I've seen that it's efficiently passage through like 13 or 14 generations. And because it's maintained within Tenacephalides felis, so the cat flea, it has a worldwide distribution. And this is adapted from a review on Rickettsioses, where we see in those red dots represent areas where fleas have been found containing Rickettsioses by molecular analysis, and the yellow stars represent cases of Rickettsioses. And certainly this was published in 2011, so there would be more red dots and more yellow stars today. So the reason it's globally distributed, as I alluded to earlier, was because of the distribution of the ubiquitous cat flea, or Tenacephalides felis. These fleas live on domestic animals, and they're distributed all throughout the world. So where there are domestic animals, there are Tenacephalides felis. It seems to be like many other Rickettsioses. This is a data from Dr. Walker with collaborators in the Yucatan, where they found molecular evidence of Rickettsioses in patients. And they had rash, fever, and half of them had headache. And in a larger series, we see that certainly fever is the predominant sign. Rash is seen in 71% of patients, although this is a small number, 34 patients. Unlike murine typhus, where I only know of one well-documented case of inoculation eschar-like lesion in murine typhus. Eschar has been recorded with Rickettsioses. And certainly, like murine typhus, people can get neurologic complications, respiratory complications. And it's only been detected molecular from patients. Been detected from blood, cerebrospinal fluid, and from skin. And at least the literature seems to say it's more reactive with the spotted fever group antigens. There is some older literature that describes it as being reactive against typhus group antigen. But from my understanding, and this is not in the literature, but passed from one person to another. I guess rickettsial folklore was that people that did the initial characterization of this organism had their Rickettsia felis stock overgrown by Rickettsia typhi. There's never, and I use the word, and I apologize, I use the word propagated here. That is incorrect. The organism has never been clearly isolated from a patient. And it has been propagated and grown from fleas, but never clearly isolated from a patient. There is a report of someone culturing Rickettsia felis from a shell vial, but reading that paper, I don't think they were able to really propagate it and passage it for cell culture. So I alluded, I think the not growing it from a human leads to a good segue involving what we don't know about this organism. So the organism is actually not just detected in fleas. but the organism has been detected in a variety of sources, including book lice, who don't feed on humans, mosquitoes, who do feed on humans, and ape feces. And how anyone ever decided to look at ape feces and what the implications of that are, I have no idea. It's also been detected in fleas, ticks, which I don't show in this slide. So there's been increasing reports of Rickettsioses in Africa. And there are many reports, but I like these two. These two are good examples because they really show that there's something going on that we don't know a lot about. It's very curious. In Kenya, in a study of febrile patients, 7.2% of febrile patients had Rickettsioses DNA found in their blood. So wow, Rickettsioses in 7.2% of febrile people. But what's odd is they also found almost 3.5% of people without fever, what we would call a control, with Rickettsioses within the blood. So that goes against really all we know about Rickettsioses. Usually, if a rickettsia is in the blood, someone should be sick. A very similar study was performed in another part of Africa, where 10% were infected with Rickettsioses, and 3.3 of the controls also had Rickettsioses DNA in the blood. Rickettsioses has been detected from, DNA has been detected from swabs of, superficial swabs of cutaneous lesions in Africa. And oddly, not only from cutaneous lesions, but it's also been detected from normal skin in patients from Africa. So some have speculated, perhaps, and actually have looked and found high prevalences of book lice within some of these villages where these samples were taken. So the thought comes in, perhaps are these cutaneous swabs collecting a skin, some sort of skin contaminant, or book louse is on the skin? So there's really a lot we don't know about Rickettsioses. I believe, I showed a study that Dr. Walker published. I believe that there are people that have Rickettsioses. It's hard to believe that detecting it in the blood or the CSF of a very sick patient means something otherwise, especially if you look for diagnoses. But there's so many other reports that are very questionable. So there's certainly a lot to be done. There are some other flea-borne associated rickettsia, and one is one called Rickettsioses, which has been isolated from fleas collected in a area of Kenya. And this has now been found all over the world. And there's also a rickettsia called Canadotus Rickettsioses, which has also been collected from fleas from Africa and Senegal, and also found in different parts of the United States and probably the world. So these are called Rickettsioses-like organisms. Some people in the literature refer to them as RFLOs. And we really don't know what the significance of their significance. They're there. They're in fleas that bite humans, but we don't know if they're contained within the fleas, transmitted to humans. So very interesting, and hopefully someone will be working with these soon and teach us more about them. So with that, I'd like to open the floor to questions, and again, thank you very much for listening.